So today we're going to be talking about LH, lymphocytic hypophysitis. It's exactly what it sounds like. It's inflammation, itis, in the hypophysis, in the pituitary gland, and it's infiltrated by lymphocytes. This is an autoimmune process. It's idiopathic. It's associated with postpartum period in young females, late pregnancy, but it can occur in any age, either gender, and at any time, including the non-pregnant state. So you should be thinking about lymphocytic hypophysitis, however, when we have an infiltrative enlargement of the pituitary gland. So as you remember from prior lectures, we have the ventricles here, and then the third ventricle, the floor of the third ventricle in coronal section is the chiasm, then the infundibulum, and in the sella is the pituitary gland. So the pituitary gland, if it gets bigger, will rise out of the sella and can compress the chiasm. If it goes laterally, it'll go into the cavernous sinus, and here's the carotid artery and the walls of the cavernous sinus, which means it can cause a third, a fourth, trigeminal, or a sixth cranial nerve palsy. So we can either have afferent problems from chiasmal lesion by temporal hemianopsia, or efferent problems from diplopia in patients who have sellar lesions, including lymphocytic hypophysitis. They often present with panhypopituitarism, but sometimes they have what looks like a prolactinoma. So they have hyperprolactinemia, which means amenorrhea and galactorrhea in young females. However, that might just be the stalk effect. So if you press on the stalk, you are interrupting the dopamine signal from the hypothalamus, and that produces an elevation in the prolactin level, leading to the syndrome of amenorrhea and galactorrhea if they have a high enough prolactin level. Often they're panhypopit, however. They might have infiltration of the stalk, which normally would not occur in pituitary adenoma alone. And the key and differentiating feature is going to be, it's going to be in the right clinical setting, a pituitary that is enlarged, but has an atypical appearance in terms of a lymphocytic infiltrative appearance, and the treatment is steroids. So as opposed to surgery, transsphenoidal resection for pituitary adenoma, we are going to give this steroids because it's an autoimmune lymphocytic infiltrative process. So in the right clinical setting, for example, a 24-year-old postpartum female who has a new onset bitemporal hemianopsia, the imaging study shows a homogeneous infiltrative appearance of lymphocytic hypophysitis. We're going to give that steroids, but the only way to know for sure what the diagnosis is to have biopsy. And on the biopsy, it's usually a lymphocytic infiltration. You should also know that we have to consider the possibility of IgG4 disease. So in the past, lymphocytic hypophysitis was considered idiopathic, but some of these idiopathic LH cases actually have IgG4 disease. And so you can look at the other video on IgG4 disease to see how that subclass restriction of immunoglobulin subclass 4 can infiltrate your pituitary gland. And the reason that's important is this IgG4 infiltration, the itis, can occur in other organ systems. It can cause thyroiditis, it can be retroperitoneal disease, it can be orbital inflammatory pseudotumor. And so the IgG4, it just goes whatever organ system it wants to go. And each subspecialty of medicine actually has its own version of orbital inflammatory pseudotumor in their organ. So ENT has it in the thyroid, general surgery has it in the retroperitoneum. Every organ has its own version of inflammatory pseudotumor. And if it's lymphocytic polyclonal infiltration, you should be thinking about IgG4. So in summary, lymphocytic hypophysitis is a disease that usually affects postpartum or pregnant females. It can present with diplopia or vision loss, usually bitemporal hemianopsia. It causes a intracellular mass with supracellular extension that can look like pituitary hyperplasia or adenoma. They might have panhypopituitarism or hyperprolactinemia, and we should treat that with steroids. And if a biopsy is done, make sure it's not IgG4 by testing the IgG4 in the serum, but also in the specimen.